Hello, everybody. On this World AIDS Day, we pause to remember all those who've lost their lives, both here in America and around the globe. And at a time when so many men and women are living with HIV and AIDS every day, let's also recommit ourselves to building on the tremendous progress we've made, both in preventing and treating the disease and ending the stigma and discrimination that too often surround it. That's why, as president, my administration has developed the first comprehensive national HIV/AIDS strategy for the United States and increased funding to fight HIV/AIDS around the world to record levels. Because it's my hope that together we can move closer to the day when we eliminate this disease from the face of the earth.
My name is Jeffrey Crawley, and I'm the Director of the Office of National AIDS Policy, and it's my pleasure to welcome you to the White House for today's commemoration of World AIDS Day. We're joined by several distinguished guests, but I would like to give a special welcome to the members of the Diplomatic Corps who are here with us. You know, we rely heavily on our bonds of friendship, and we're so thankful for their partnership in fighting AIDS, and we're glad that you can join us here today. I also know it's risky to single out one federal official because we have so many strong leaders across the government, but I did want to acknowledge Dr. Ronald Valdesari from the Department of Health and Human Services, who is here. Those of you that have been following closely know that when we released the National HIV/AIDS Strategy, we've had a lot of activities across the federal government, but we've really put a lot of responsibility on Ron's shoulders, so we do want to acknowledge that you're here and thank you for all your hard work. So President Obama has provided critical leadership in responding to HIV/AIDS, both in the United States and around the world. And we hope that today's meeting will provide a thoughtful dialogue to really take a look together about where we've been and where we're going. Now, before we get started, I wanted to pause for a moment and acknowledge the passing of a friend of many of us in this room. Randy Algar is a person with AIDS who died this past Saturday morning. And you know, he's a longtime advocate and policy wonk and friend of many of us. You know, for years, he was talking about Medicare when few people in the HIV community were. And you know, it's the second largest source of health care for people with HIV and AIDS. More recently, he's been part of a national working positive coalition, really taking a look at some of these complex policy issues that really become barriers for people living with HIV re-entering the workforce. And so he was a close friend, but he also did a lot of really important policy work. And so his passing reminds us of the important work that remains ahead of us. So I would also just like to quickly acknowledge many people here that help us pull together any event like this. I have a great team in the Office of National AIDS Policy, but James Albino, who's my senior program manager, helped coordinate today's event, so I thank him. Karen Richardson is a key partner in our Office of Public Engagement, and she was heavily involved. But this is really intended to really balance our work on domestic AIDS and global AIDS. And you know, we've worked closely and thank Gail Smith and Mark Abdu of the National Security Staff and Dr. Zeke Emanuel, the National Economic Council, who are really part of our brain trust on global health issues, so we acknowledge them. Now, to get us started, I'd like to introduce the Reverend Kimberly Brown Barnes, who's going to offer a moment of reflection.
Good afternoon. HIV/AIDS, what have we learned and where are we going? For the past 29 years, we've learned about this AIDS pandemic that has spread throughout the global community because of HIV infection. We've learned that this disease started in one community and has spread to all of humanity. We've learned that over the years, people have been fearful due to ignorance. We've learned that people have been ostracized because of fear. We've learned that everyone deserves to be treated with dignity. We've learned that every life has meaning. We've learned that surprisingly, some people do not think that this disease still poses a threat. And we've learned that we still have a lot of work to do. As we reflect on our professional and personal journeys of dealing with this disease, many of us do think about the many lives that have been lost. We remember our friends and loved ones with joy and at the same time sadness. We hold memorials to honor those who have passed. Yet at the same time, we honor the living. We honor those who are HIV positive for their courage and strength. We honor those who have and continue to dedicate their time and effort to provide awareness, education, counseling, and simple human compassion to combat this disease. As we think about all who are gathered today, who have been dedicating their lives to this great work, I cannot help but see that we have a communal, tenacious spirit to not accept defeat. I do not believe that it is an accident that December 1st is the day in which we choose to recognize AIDS. For me, it is God's hand moving among us. For at this time of the year, our Muslim brothers and sisters would have already celebrated Ramadan, in which they take the time to fast, to intensify their prayer life, and to commune with God. The Christian community is now in the season of Advent, awaiting the birth of Christ and celebrating his life and gift of God's saving grace to humanity. Our Jewish brothers and sisters will be celebrating Hanukkah, in which they celebrate the rededication of the Holy Temple that is a communal experience. Whether Muslim, Christian, or Jew, we are looking to connect to God, but we are also being reminded that we are connected to one another. I believe that the African theological concept of Ubuntu captures this best. Ubuntu means that my humanity is inextricably bound up with yours, so that we can only be humans together. We are a human family, and as a family on this day, we remind the global community that we stand firm and we are each other's keepers. Whether we shed tears and offer comfort to victims of sexual assault who have been infected in the Democratic Republic of the Congo and in Darfur and the Sudan, whether we are working to bring awareness and education to young people in New York, Chicago, New Orleans, San Francisco, or Washington, D.C., whether we are providing services in rural communities or to our Native American brothers and sisters, wherever we are serving and whoever we are serving, we are demonstrating our inextricable connection to one another. With the spiritual and religious richness that surrounds World AIDS Day, we may be weary, tired, and frustrated, but we are hopeful. Hopeful that through continued awareness, education, and campaigns, our human spirit is tenacious in pursuit of not just a cure, but that every life is treated with respect and dignity. Now, I would really like to leave you with some deep theological thought, but I am an old school rhythm and blues girl. So I have to leave you with this wonderful song by Frankie Beverly and Mays, entitled Before I Let You Go. Now, if you don't know the song, Frankie Beverly is singing about a woman he loves and refuses to let go. I believe that as activists, advocates, humanitarians, and clergy, when it comes to combating HIV/AIDS, we just cannot accept defeat. We cannot accept letting go of the battle. We cannot accept letting go of another life. We cannot accept letting go of any person in need. We cannot accept letting go of any orphan child. We cannot accept letting go because we have learned a few things along the way, and I believe that we are heading in the right direction. God bless each of you.
Thank you, Reverend Barnes. Now it's my privilege to introduce Melody Barnes, who's an assistant to the president and the director of the Domestic Policy Council, who's going to provide some opening remarks. Melody?
Well, good afternoon, everyone. It is a rare pleasure when a Barnes gets to follow a Barnes. And we have to find out if we're related, in fact. But I also want to thank Reverend Barnes for that really lovely moment of reflection. You know, I think we all probably rushed in here. I know I did. Crazy day, busy day, and recognizing how important this is. But that was a moment to stop and to think and to reflect. And I personally appreciated it, so thank you very much. And I want to welcome all of you to the White House. Today we commemorate World AIDS Day, and certainly not just through our words, but also through our deeds. we are recommitting ourselves to working for a world that exists without AIDS. And we're gathered here today to examine the progress that we've made on two fronts, both ending the domestic epidemic while we're also continuing our work around the globe. We are desperate to end the pandemic that affects so many people everywhere. And these are really two sides of the same coin, even though we don't often stop to think about the way, as Kimberly so beautifully said, they are inextricably linked together, and how they are mutually reinforcing. Our work is mutually reinforcing of itself. We've certainly come a long, long way since World AIDS Day 2009. Last year, after President Obama eliminated the entry ban, we announced that the International AIDS Society would hold the 2012 International AIDS Conference in Washington, D.C. In the past 365 days, my colleagues in the White House and our colleagues across the administration have begun work in earnest with the IAS to make the 2012 conference a success on par with its importance. And this time last year, many of you were also engaged with us as we were starting to wind down our community conversations that were sponsored by the Office of National AIDS Policy that Jeff runs and runs so well with a really terrific group of colleagues in the Domestic Policy Council. And since then, as you know, we've been able to release the National AIDS Strategy, the first domestic HIV/AIDS strategy our country has ever had. And I think we're particularly proud of this for two reasons. Obviously, and most importantly, because it puts us on the path that we need to be on to reduce the scourge of HIV/AIDS. At the same time, it is important because the President made a promise on the campaign trail, and he fulfilled that promise. He has stuck with all of us and committed himself to refocusing attention on the domestic HIV epidemic and to provide an essential roadmap for our nation to move forward together. From our perspective, we cannot say often enough that this is not a federal plan. This is a national plan. It is a national strategy. We continue to be excited and grateful for all the work that many of you have done with us, for the work that so many have done across the government and in communities across the nation. The level of commitment and engagement that we have received from our external partners has really been unsurpassed. So thank you for that and for all the work that is to come. But I don't have to tell you that our work has only just begun. We're now engaged in the most important part of this task, and that's moving beyond the strategy development to the meaningful implementation of the strategy. In July, when we released it, the President directed lead agencies to develop operational plans for implementing the strategy. Those are due to us next week, and we look forward to reviewing them. He also tasked the Secretary of State with helping us to apply lessons that we've learned from PEPFAR to our domestic efforts. Ambassador Goolsbee is leading that charge, and we are very much looking forward to his recommendations. Last March, the President was also proud to sign into law the Affordable Care Act. And when you hold this important piece of legislation to the light, and you look at its many different facets, what we realize is that this new law was really an essential piece of HIV legislation. The new law already provides meaningful support for people living with HIV/AIDS by ending lifetime limits on benefits and ensuring other critical consumer protections. Beginning this year, a $250 rebate will be provided to people with HIV/AIDS in a Medicare coverage gap that's commonly known as the donut hole, as we work to phase out this gap completely. In addition, starting in 2011, AIDS drug assistance programs benefits will be considered as contributions toward Medicare Part D's true out-of-pocket spending limit, the donut hole, a huge relief to people who are living with HIV/AIDS. It also includes a new pre-existing condition insurance program that creates a new option to purchase insurance coverage for people who are uninsured due to a pre-existing condition. States also have new flexibility to extend Medicaid coverage to low-income people, including people living with HIV. Of critical importance, in 2014, the Affordable Care Act will expand access to affordable insurance coverage by extending Medicaid to all people with an income below 133% of poverty, and giving higher income people access to a choice of insurance options with income-based subsidies through state-based insurance exchanges. Clearly, expanding access to insurance coverage is a cornerstone of our efforts to increase access to care in order to provide the clinical outcomes experienced by people living with AIDS. On the global front, in October, we announced an unprecedented multi-year pledge of $4 billion for 2011 through 2013 to the Global Fund to fight AIDS, tuberculosis, and malaria. This pledge represents a 38% increase in U.S. support for the Global Fund and is in addition to the more than $5.1 billion provided to the fund to date. And last month, the United States signed its 17th PEPFAR Partnership Framework, laying out 5-year joint plans between the United States and partner governments for cooperation in the fight against HIV/AIDS and helping to foster a shared response. These frameworks help to strengthen the country capacity, ownership, and leadership, building on successes achieved to date, and ultimately to saving more lives. And last but certainly not least, this past year has also been just a phenomenal, exciting year in terms of research. In the summer, we learned of promising results for the development of an effective vaginal microbicide, and just last week, and I don't have to tell you all there, we were all just reading with interest and looking forward to the new developments around the exciting results that were announced related to pre-exposure prophylaxis, or PrEP. These findings are preliminary and they raise many questions, but they remind us of the payoffs that are available to us from our research investments, and they promise that important new tools for our HIV prevention toolbox are at hand. We'll hear more about this from Dr. Fauci later today, and look forward to hearing more and more about the exciting work that is to come. The challenge of ending a pandemic is obviously large and complex. We live in times of difficult choices and very painful trade-offs, and clearly there is much work ahead of us. But as we think about our current challenges, you should know that we have a president who is a committed leader and partner in the work to save lives and to maximize the results from our HIV/AIDS investments in the United States and around the world. So with that, it's now my pleasure to introduce one of our phenomenal leaders in the administration, someone who spends his days and nights working to promote the health of people both in developing nations and in the United States around the world, Dr. Rajiv Shah, the administrator of the USAID. Raj.
Thank you, Melody, and I also want to thank Reverend Barnes for that, for those comments, which do, when you're coming in from the cold and from the rain, set the tone in a very different way. I want to thank Jeff Crowley for your leadership and for the great work that you've done, and of course, Ambassador Goosby and Tony Fauci, who will get a chance to speak to you today. You know, I wanted to just highlight that over the past 30 years, we've all come to recognize, mostly due to the great work of leaders in this room and in this community, that HIV/AIDS is a virus, it is an epidemic, it is a tremendous cause of loss of life and untold amount of suffering, deep human suffering that many of us have had the chance to visit with families and be part of communities that have experienced that suffering. But it has also come to be a symbol of the critical development challenges that exist in the world as people began to realize that societies and countries cannot effectively develop without the human resources and the freedom from such a ravaging epidemic. And it has become, perhaps much more recently, a story of innovation, progress, partnership, and hope, in part because of the great successes of so many of you in this room who've seen those successes on vaccine research, on microbicide research and breakthroughs that Melody spoke about, on PEPFAR's exciting and tremendous progress. And I was thrilled today to receive the press release from the State Department that Ambassador Goosby released announcing that 3.2 million people have been saved worldwide because of this effort. It is a demonstration of what's possible when we all come together against a specific goal and with a relentless commitment to succeed, and with an operational focus on making sure we save lives, we count them, and we report on them. I think it also inspires all of us that we can reach the GHI goal, the Global Health Initiative goal of treating more than 4 million people by 2013. USAID has the honor of implementing about 55% of the PEPFAR program, and on a day like today, it is an honor to recognize the great achievements that those teams have achieved in implementation of that work. We know, and we'll have a chance to discuss, I'm sure, at the panel, the challenges ahead in terms of prevention, further treatment, expanding the effort, and using the tremendous health platform that PEPFAR has created to provide a broader range of health services to people who are in desperate need and in a way that can maximally improve the quality of life and the reduction of suffering. Just yesterday, yesterday or Monday, we were part of an exciting meeting that was following up on the CAPRISA trial and following up on developing a strategy forward. And a number of the partners from South Africa, from the FDA, from NIH, from CDC, all recognized that in fact, global health is a field where even when we have great breakthroughs, and even when we have real reasons for hope, we still too often see 10, 15, 20-year delays in getting the kind of uptake and impact of promising new breakthroughs around the world. And I was so excited about the discussion during that day because by honing in on that reality, it demonstrated that this community was going to be much more serious with these important HIV prevention breakthroughs, whether it's the CAPRISA trial and what that leads to, or the IPREX trial and what that may lead to, or so many other applications of antiretrovirals in prevention, that we can accelerate that work in a very fundamental way if we take some learnings and lessons from the private sector, from PEPFAR's successful program to date, from the vaccine community that has tried to accelerate introduction of new vaccines in complex, difficult, and resource-constrained environments around the world. And if we stay singularly focused on that and try to do that with all of our effort and energy and demand more resources and demand more excellence and demand more focus on making sure we adequately protect people, we can actually achieve tremendous successes. I'm pleased to note that USAID will play a significant role with NIH and PEPFAR and others in helping to usher in that focus on HIV prevention and with some of those new prevention strategies. I was very excited to learn about Swaziland's program, where we're all working in partnership to increase circumcision among men between the ages of 15 and 49 to more than 80% in less than 1 year. It's the kind of an example of rapid scale-up of data-based and proven interventions that can really make a difference, both in terms of health outcomes, but also in terms of giving us all the confidence that when we find things that work, we can scale them up rapidly and do that in a successful and focused way. I think that effort alone is modeled to avert 88,000 new infections. And in addition to the huge savings in terms of life and quality of life, that will generate more than $350 million in savings to that society that can then be used for other activities. So I don't want to go on today with a community of people that know this issue much deeper than I just want to share with you my deep respect for what you do, for your work and your commitment, for proving to the world that often didn't believe you could reach such high treatment numbers, or you could achieve such rapid scale-up of circumcision, or you could move so aggressively to see successes on microbicides and other applications of antiretrovirals for prevention, and for continuing to demonstrate that we're going to get a vaccine someday by staying focused aggressively on that task, that in fact, when a lot of people say it can't be done, you prove time and again it can. And we take inspiration from that today, and I'm honored to be here, and I appreciate your great leadership. I have the opportunity to introduce Dr. Tony Fauci, who really needs no introduction in this environment, a great scientist, the director of the National Institute of Allergic and Infectious Diseases, the intellectual and father, amongst others, of the PEPFAR program, and someone we all look to for continued guidance as we seek the next level of breakthroughs that will help change the world. Tony.
Thank you very much, Raj. It's really a great pleasure and an honor to be here with you this afternoon to commemorate World AIDS Day. It's always, for me, from someone who has been involved in this issue since the very first day, to use this day to reflect in a somewhat bittersweet way both the suffering that we've seen, the accomplishments that we've made, and more importantly, the challenges that lie ahead of us. I'm going to talk for just a few minutes about some of the areas of HIV research, importantly over the last few decades, that brought us to where we are right now, that have enabled PEPFAR and USAID and other agencies to implement some of the most important advances that we've seen in any medical field, and on the other hand, to be able to realize the challenges that remain and try and forge a path in that direction. I want to just mention briefly to you 3 issues that many of us have been speaking about over the last several years. One is the optimization of therapy. The other is the seeking of a true cure for HIV infection. And the third is the maximizing of prevention. So let's take the first for a moment, the optimization of therapy. There's extraordinarily good news here, but as we all know, we can do better. You know the numbers. We have 30 drugs that are used in combinations. Probably the most impressive success story of the rapid translation of fundamental basic research in understanding the virus and its targets and the development of usable therapies. I could not help but reflect when I made rounds this morning. I make rounds 3 days a week at the NIH, and I've been doing that for too long because I don't really want you to know how really old I am. But I do it every week, Monday, Wednesday, and Friday from around 10 o'clock to around noon. And when I made rounds this morning, reflecting on this being World AIDS Day, I recalled with great clarity the first patients that I admitted to the NIH Clinical Center, which is just about 5.5 miles north of here, during the summer of 1981, when we didn't know what it was or where it was going, but it was making these young men, predominantly young men, very, very ill, and virtually all of them were dying. The life expectancy of a patient that would come into my ward in the summer of '81, who albeit came in with advanced disease, was 26 weeks. I made rounds this morning at 10 o'clock on a bunch of patients that we had been following, and it was such an extraordinary feeling to look them in the eye and know that if that person was a 20-year-old who came into the clinic newly infected with HIV, who we put on appropriate therapy, that I could tell that individual that mathematically modeling, they will likely live another 50 years to the age of 70. That's the extraordinary news, but many challenges remain. There's always the great news and the challenge with HIV. That seems to be our fate from the very beginning. What needs to be done? We all know this. Access to therapy. Access that starts with finding out who is infecting, getting to them, bringing them into care and treatment if necessary, and counseling them. Again, getting back to my own personal experiences, just last week we admitted someone who lives in the District of Columbia who presented with CNS lymphoma and CMV enteritis with a CD4 count of 4. That is completely unacceptable today, but that's what we see every day. So what do we do about that? You talk about domestically access to care. There are programs that have been launched that are accelerating now everywhere here in the District of Columbia and cities throughout the country to get early penetration into the community, testing and getting under care. Globally, with the extraordinary work of PEPFAR and other organizations, we have now over 5 million people in low and middle income countries who are receiving therapy. When I first went down to, not the first time I went to Africa, but in the early 2000s when we went to Africa to put together the PEPFAR program for President Bush, there was less than 50,000 people on therapy, mostly people who could afford therapy. Now the numbers are extraordinary, but there's much more to be done. What about treating patient early? There's no doubt now, no doubt at all, in December of 2010, that the earlier you put someone on therapy, the better it is for the patient. And we also know that it's less expensive in the long run to treat somebody early and avoid the kinds of hospitalizations. So what we need to do is to use that data to continue to stimulate us to get people into therapy at an appropriate early time. In addition, we need to optimize therapy and know now that we have other things that go on with HIV-infected individuals as they live longer: heart disease, liver disease, diabetes, psychiatric disorders, diseases of aging. These are the challenges that are related to treatment. What about cure? I totally believe that we will be able to cure HIV in a subset of individuals. Now, what do I mean by a subset? People get nervous when I say that. I think a subset is someone who you can get into treatment early enough so that they don't have an enormous HIV reservoir that you're going to have to get rid of. In my own lab, we've been doing studies over the last several years that show if you look at the size of the reservoir, and why do I bring up the reservoir? The reservoir of HIV is that which you have to eliminate if you're going to cure somebody. And if you look at people who start therapy within 6 months of getting infected versus people who start therapy after years of being infected, the size of that reservoir is enormous. If you start with a small reservoir, then we could use the new therapies that are being developed, the possibilities of gene therapy to eliminate that and in many respects develop a cure. And then finally, what about the issue of maximizing prevention? We need and are scaling up prevention modalities. And as was just said by Ms. Barnes, this has been an extraordinary year. If you push the year to about a year and a half, 3 major transforming things have happened in HIV prevention. The Thai trial that we're all familiar with, which was the first real signal, modest though it may be, that a vaccine can actually block acquisition in vaccinated individuals. We need to do much better than that, and a lot of effort is being directed towards doing better than that. The next was the Caprices study, another extraordinary proof of concept. For the first time in the many years that we have been studying topical microbicides, the big difference that this was a microbicide that had an antiretroviral in it. The numbers of 39% efficacy, modest, but highly significant. An important aspect is those who used it more did better. And then the thing that has really excited so many of us is the recent results from a couple of weeks ago on the PrEP study IPREX, in which all comers, the results of oral tenofovir in men who have sex with men was 44%. But I don't need to tell this audience that there's some subtext to that that really tells us what our challenges are. 44%, if you look at everybody. If you read the paper carefully, a substantial proportion of people who said they were taking the drug, in fact, were not taking the drug. So if you look at individuals who were saying that they take the drug 90% or more of the days, the reduction in risk of infection compared to the placebo was 73%. Even more importantly, if you divide it into people with blood levels versus those who do not have blood levels, and blood levels don't lie, the decrease in risk was 92%. That tells us it's an important proof of concept, but it also tells us with the Caprices study that adherence is everything. And that's the thing that we need to combine with our biological prevention modalities, getting to individuals to understand the importance of adherence. And I call that part of the combination prevention modalities. And I want to really emphasize in my last minute that when we talk about prevention, whether or not we get an effective vaccine, which is a great challenge that I think we'll meet, prevention will never be unidimensional. It must be combination and multifaceted. So that's been a phenomenal year to a year and a half. So let me close with the thing I say always when I talk about HIV/AIDS, and that is there's much that we've accomplished, but much to do. So I'm very excited to be here today with you on World AIDS Day and to talk about what has been accomplished. But as I mentioned earlier, I'm quite sobered about what we still need to do. So let us use this day to reinforce in each other the commitment to sustain and increase the momentum so that someday, and I hope in the not too distant future, World AIDS Day will be a commemoration of something in the past as opposed to a challenge that we still need to face today. Thank you. So now I'd like to take this great pleasure of mine of introducing a very close friend of mine, a person who really needs no introduction, Eric Gooseby, who's the United States Global AIDS Coordinator. I had the privilege and the pleasure of knowing Eric from the very, very early days of the AIDS epidemic when he was taking care of patients at San Francisco General as I was taking care of patients up the road at the NIH. And we have been partners through it all over the last several decades when he served in the Clinton White House and the Department of Health and Human Services as the Deputy Director at the White House of the AIDS Policy Office and the Director of the AIDS Policy Office at HHS, and now is serving in such a spectacular way that we're all so proud of you, Eric. Please come up.
Well, thank you, everyone. It's a really kind introduction. I appreciate it. It's wonderful to see so many people that I've known for so many years in the audience, and I thank you for coming today. It's really a pleasure, though, to be here on so many levels that we've heard from many of the distinguished speakers. So many of you have been engaged in this work for really 30 years, many of the faces in this room. You've made huge contributions both on an individual level, and you know those contributions well personally, but also on a broader level. Your work has been expanded at home and abroad. Even though the challenges change from year to year, and the facts are that things are so different today from even a few years ago, the advances we hear about and the implications for these advances to move to implementation. You're all still in the fight. For that, I thank you humbly and acknowledge, as Tony said, that there is much to do and we have much to look forward to in engaging. I'd also like to thank the President, President Obama, Secretary Clinton, Secretary Sebelius. I'd like to thank Jeff for his leadership and all of the implementing agencies that we work with to make this happen. The Obama administration's commitment to investing in HIV/AIDS prevention, treatment, and care is unwavering. The President has launched the Global Health Initiative, which I am convinced will make PEPFAR even more effective. As this group knows so well, no one is defined by a single health condition, even one as serious as HIV. One of the major goals of the Global Health Initiative is to better enable us to address the whole range of health problems and needs of the people we already serve, and that's an exciting opportunity. For PEPFAR, on this World AIDS Day, our theme is smart investments Building on Success. It describes what we are doing every day at PEPFAR. The smarter we are about the prevention, treatment, and care we provide, the greater the number of lives we are able to save. This remains and always has been our bottom line, because our yardstick for measuring success is not dollars, but the number of people we touch and the number of lives saved. I'm pleased to share with you today the brand new, very encouraging results achieved by our results. Through PEPFAR, the United States is directly supporting life-saving antiretroviral treatment for over 3.2 million men, women, and children, an increase from less than 2.5 million 1 year ago. In the coming years, the United States is committed to directly support more than 4 million people on treatment. This more than doubling the number supported during the first 5 years of PEPFAR. Support for prevention of new HIV infections and for care and support for those affected by HIV are other areas of encouraging progress. To date, PEPFAR-supported programs to prevent mother-to-child transmission have allowed 600,000 babies of HIV-positive mothers to be born HIV-free, including 114,000 infants in the fiscal year 2010. Through its partnership with more than 30 countries, PEPFAR directly supported 11 million people with care and support, including 3.8 million orphans and vulnerable children in fiscal year 2010. In addition to PEPFAR's impact, many also benefit from programs supported by the United States and other donors through the Global Fund to fight AIDS, tuberculosis, and malaria. The United States is the first and largest donor to the Global Fund, providing more than $5.1 billion to date, and the administration recently announced an unprecedented multi-year pledge that Melody alluded to, $4 billion to the fund, representing a 38% increase in the United States support. As we build on this success, what is the way forward for PEPFAR? Years of experience in the field have not gone unacknowledged, and indeed we have learned from these experiences to be efficient and effective in the use of our money and investment in battling AIDS. It means investing more in evidence-based prevention, in supporting more effective and cost-effective treatment regimens, and leveraging our investments through effective collaborations with partners. It means strengthening the interagency model that has been so integral to our success. In our model, each of our implementing agencies, Health and Human Services, Department of Defense, USAID, Peace Corps, contributes unique core competencies to our work. The Global Health Initiative, with its own interagency structure, builds on this success. And finally, building on success means continuing to work with you and our partner countries to listen to your insights as we pursue our shared mission. I want to thank you for your partnership with PEPFAR as we pursue a future free of HIV/AIDS. I now would like to take this opportunity to introduce the panel that can come up now as I'm talking about you. I think you can come up and have a seat in the chair. Dr. Rodorda Ademora is a physician epidemiologist at the University of North Carolina School of Medicine. She published the first national data on concurrent partnerships in U.S. women in the conceptual analysis of contextual factors that promote concurrent sexual partnerships among African Americans. Jen Cates, well known to all of you, is Vice President and the Director of HIV Policy at Kaiser Family Foundation, a nonprofit private operating foundation. She oversees all of the foundation's HIV/AIDS policy efforts, directing and conducting policy, research, analysis focused on both the global and domestic epidemics. Chris Collins is Vice President and Director of Public Policy for AMFAR, the Foundation for AIDS Research. He co-founded the AIDS Vaccine Advocacy Coalition and is Chief Advisor to Representative Nancy Pelosi on HIV/AIDS and health policy. He developed the first legislation designed to provide incentives for the development and delivery of vaccines against AIDS, malaria, and TB. Dr. Mupali Das is a physician researcher at the University of California, San Francisco, a place dear to my heart. Dr. Das's research interests include HIV health and treatment outcomes in the homeless and marginally housed urban poor. Finally, my close friend and mentor, Dr. Tony Fauci, truly has been in a leadership position since the beginning of the epidemic, and as Raj said, has guided and advised us all at points of confusion and clarity, and we'll always be grateful for his continued contributions. So I'm going to move over to the table. We're going to start with a couple of questions that allow each of the participants to focus on a specific question. What I thought I would start with is Dr. Adamora, since we're here and sitting next to each other. You know, your work has really been impressive and illuminating. It highlighted a lot of the issues that we have looked at really since 1994, when we saw an increase in the African American seroprevalence rates moving up and have stayed up really since that date. The vulnerability to infection that we have seen globally in different populations is also reflected in people's ability to be identified, to be entered in care, to access therapy and treatment. What concepts have you been able to kind of identify and steps that you might be able to articulate that would be needed to better identify, enter, and retain, especially Black women in the United States, in care and treatment?
Well, several things. I mean, some of the things that I was thinking about are related, but don't necessarily directly address that. I'd like to say first, thank you for asking me to be here. And I really do applaud the administration's efforts in combating the HIV epidemic. Really, really, and truly, we do all appreciate them.
Thank you.
I mean, I think that there are several principles. One is that several general principles. Anything that affects Black men affects Black women, because typically 80% of Black women who have HIV have acquired it from heterosexual transmission, usually from a Black man. So that anything that affects Black men affects Black women ultimately. A second principle is that some issues are very clearly out of control of the federal government, but I think that a really major task is going to be to incentivize states, local governments, and actually the private sector to comply with policies that are deemed advisable. And a third thing is that Dr. Fauci said no one intervention, even a vaccine, is going to fix this situation. So several things that I was thinking of are first, of all the stunning advances that we've seen. I think that one of the things that's going to be critical is to answer some of the questions about how these latest advances, IPREX, the CAPRISA trial, how are these advances going to benefit, and how do they apply to Black women in the U.S. at all? For example, what is the acceptability of these interventions? What are the risk-benefit ratios, given that Black women in the U.S. are in a setting where risk of transmission is somewhat high, but it's not as high as it is among MSM, and it's not as high as it is in South Africa. What is the acceptability of pills, daily pills? What's the acceptability of a gel? These are all issues that I think are going to need to be addressed in a research setting. Secondly, here's some concrete things that I think we need to do. Again, anything that happens to Black men affects Black women. I think, a lot of these things are already known. We have data for them. Circumcision. I think we need to make sure that circumcision is paid for. We clearly need to, to reimburse circumcision of male infants. It's been demonstrated about 3/4 of Black men in the U.S. are already circumcised. So and people, this is clearly an issue. Third, concerning one aspect of your question, I do think that we need better information concerning the seroprevalence of HIV infection. In fact, I would really consider a return to something like the studies of HIV seroprevalence among childbearing women that were done in the U.S. to have better information about really and truly where HIV infection is in the general population, not just venue-based and respondent-driven sampling. Another issue is, I mean, again, some of these things are so mundane, but the issue is, you know, implementation. Condoms. I mean, you know, although condom use is inconsistent, part of the reason for their inconsistent use, part of it, is that many people simply can't afford them. One thing, in fact, this has been said by, you know, Tom Frieden. One thing is they need to be universally accessible to increase use among the many people who would, in fact, use them. I can't resist this. I know, you know, I'm going to say this. I'm going to let other people move on. But I think some of these social factors are really, really critically important, and they have to be addressed. Look, for example, at incarceration. I mean, incarceration, the disproportionate incarceration of black men in the United States is linked to HIV infection in the black population by so many very clear pathways. We need to decrease that. How? Well, obviously, I don't know, but I would consider alternatives to incarceration for nonviolent crime. I mean, the states are currently being crushed under the weight of paying for incarceration. And secondly, really looking at the extraordinary racial disparities in sentencing that exist, not just for drug use, but in sentencing for essentially all convictions in the United States. I think that really needs to be a focus, actually, of the Justice Department.
Well,
This would help HIV.
Thank you. Those are excellent points. Let me just get the rest of the panel involved. Dr. Das, your work with communities and looking at community viral load levels, how might you tie this in for high-risk populations within a larger community, African American populations, MSMs, injection drug users, sex workers? How would you use your tool that you're looking at and trying to refine, help us better target populations?
Thank you very much. First, I'd also like to thank the organizers for the opportunity to be here. I think it's very important to remember the old performance adage, what gets measured gets managed. And community viral load is really a population-level indicator of how well we are doing with combination prevention approaches for care and treatment, prevention, care, and treatment in the United States. As a clinician, I measure viral load in my individual patients to see how well treatment is going. As a public health official, I look at the overall measure of community viral load, the aggregate number of virus particles in a city, in a geographic region, or the average number of virus particles among different subpopulations to look at how well we're doing in terms of uptake of antiretroviral therapy, linkage to and engagement, and retention and care. So, for example, in San Francisco, there are certain neighborhoods and subpopulations, groups within the larger groups of people at risk for HIV who have extreme disparities in their average community viral load. For example, transgender individuals, African Americans, and Latinos have higher viral loads than the overall San Francisco mean. This not only allows us to highlight the disparities that exist, but also allows us to better target our diminishing public resources so we can help alleviate these disparities and reduce new infections and improve care and treatment outcomes in San Francisco.
Well, thank you. Jen, you've been at this a long time, have seen both the domestic response, both you and Chris were integrally involved in pushing for the strategic plan, the strategy, pushing that out. I'm curious if you, with your both domestic and international experience, have identified kind of some lessons that might be appropriate that go from both a PEPFAR Foundation back to the United States or from the United States to PEPFAR.
Yeah, thank you, Ambassador Gooseby and Jeff Crowley and everyone else who organized this and for including us today. It's really an honor to be here. There are many lessons. Some of them are not, they're not rocket science all the time, but there are lessons that we always need to come back to. And I was thinking about this. One of the lessons that I have been thinking about recently is the connection between national and local, and how a government overall approaches or prioritizes a response, and then how that translates to local communities. That's something that I think through PEPFAR was really emphasized around focusing efforts in certain countries, not at the exclusion of other countries, but really saying we want to concentrate efforts and increasingly working with governments as well. So it's working with governments and working with local communities because HIV is local at the end of the day, as Ada was saying. And in the U.S., I think that has more recently been the marker of the National AIDS Strategy, where there's been sort of a government-wide approach, but now increasingly discussion of a focus on communities, the 12 communities, for example. So I think that is an important lesson. It may seem obvious, but it's not one that we've always followed in both places. And it's one that I've noticed and think could benefit. For example, one of the things that the foundation has been quite involved in is media partnerships. And I do a lot of the policy work, but I get really excited about getting to do the media partnerships because it's some of the most innovative areas that we get to work in, and it really is about public-private partners. And harnessing the power of the private sector in ways that has been done, I think, internationally, and hasn't always been done here. I have one example. We have long-standing work in the U.S. working with a media company, for example, MTV or other media companies, on doing outreach and information on HIV awareness. We've not had success until recently in the U.S. in creating partnerships between media companies. Globally, we were able to do that with the Global AIDS Media Partnership, with UNAIDS and others, and there was a real sense of urgency that putting aside business rivalries and competition was needed. And that recently is happening here with the Greater Than AIDS campaign. So that's another lesson that when the urgency of something is put forward, I think the private sectors and other partners are really ready to step forward.
Well, thank you. Chris, let me pull you into this with, the strategy, the National AIDS Strategy is completed. A lot of work went into it. How do we best ensure that the thinking and the ideas that were put forward in the document move to implementation and to ground and that we benefit from them?
Well, I also want to say thank you very much for the invitation. It's an honor to be here. I think the strategy, the National HIV/AIDS Strategy that the President released in July is a really bold step forward in the domestic response to HIV in a lot of ways. One is it's focused solidly on achieving outcomes, and that's something we've needed a long time in the domestic response. It's something I think that we can take from PEPFAR that we need to apply here. The strategy that we've got is certainly a very good first step. To achieve the worthy goals that the President laid out in that strategy, we're going to need implementation that's equally as bold. And I think there's a few elements that go into that implementation. One, for government, we're going to have to change the way we do business in many ways. We're going to have a much more coordinated and accountable system across the federal government, but also with state and local. I personally think that the 12-city plan that CDC initiated and now HHS has adopted agency-wide can sort of be the Trojan horse of systems change that we need here, because if it's done right, it can really force coordination between various agencies, HRSA, CDC, NIH, et cetera, in the way we need. A critical element, though, of that 12-city piece, which is an idea to really focus on epicenters, look at what works, and then hopefully export that out to the rest of the country, a critical element of making that work is scale. One of the things we failed to do in this country is deliver services at the scale we need to have the impact that we want. So we heard several months ago from a survey of CDC that they did in 21 urban areas in the United States among gay men, 71% of young gay black men who are living with HIV don't know it. With that kind of coverage level, we're simply not going to get near to the strategy goals that the President's laid out for us. To accomplish the scale we need in those 12 cities, it is going to take resources. Now, we all know this is a tough budget year, but it is going to take money. We're not going to get the strategy goals done without new investments. There's a few ways I think we've got to loosen up money. One, we need new money in the FY12 budget request. I can't think of a year when you could better make an argument for new funds. We've got ADAP waiting lines. We've got a new strategy. We're going to use funds more strategically. In addition, though, we need to make tough choices about loosening up funds where they're not having impact. Let's do an audit of funding and prevention and care, and where we're not having population-level impact with our interventions, we need to take a hard look at that kind of money. We need to open up blending of resources so that local and state actors can use the 20, 30 different streams of money they get in and can combine them and use them with more facility so that they can go to scale. So I think there's a variety of things that we need to do there. The last thing I'll say about this isn't just about government, as people in government are always saying. I think that's absolutely true. Community actors, who are the backbone of this whole effort in the United States and globally, also, we have to be looking at changing our efforts just as the government is. And I think everybody's job is different if we do this right. I think that some of the work that Dr. Doss is doing on community viral load, what we're hearing from PrEP, what we're seeing about the impact of treatment on prevention, it suggests that down the road, community providers are going to have an increasing role, continually a critical role, but play more of a role in terms of linkage to care, helping people stay in care, making the healthcare system work better for people who are estranged from the healthcare system right now. So roles are going to have to change. Everyone's going to have to be more transparent and accountable. I think that those are the places we need to go to make this strategy effective.
Thank you. Tony, if I could ask, in having heard all this, and looking at the different types of interventions that we make in an area that is a little outside of your central expertise, but I know you're deeply experienced in thinking through it, is combination therapy around prevention. How do you decide in what's appropriate, what combination to use, differences in populations, different opportunities presented? I'm just curious if you have thought what your thoughts are on how to figure out what that perfect combination might be.
Yeah, thank you, Eric, for the question. I don't think there's going to be a perfect combination, but when you're looking at a very bold concept of using potentially and in reality toxic drugs to prevent something, you have to take certain things into consideration. And those were the things that actually were considered for the choice of Truvada for the PrEP trial. First of all, you wanted to have something that you were pretty sure worked. And Truvada had close to 10 years of experience as 2/3 of the most popular combination used, certainly in the developed world. As we all know, it's used with efavirenz or with a protease inhibitor or with another non-nuke. So we know it works. Secondly, you wanted favorable pharmacokinetics, which it has. You want to have an animal model in which it works in, and this drug does work in an animal model. And you wanted to have minimal toxicities, which in fact, every drug has toxicities. Tenofovir with renal, there was some nausea in the study. So you try and weigh it in a way that people have asked, does this mean that tenofovir and tricidebon is it after Truvada? No, I think we'll continue to explore as new drugs come online those major characteristics: low toxicity, good pharmacokinetics and pharmacodynamics, and efficacy. So to me, that's the bottom line of it, scientifically based.
Very good. Any reactions to what's been discussed around those last 2 points? It raises the question of how are we going to be able to translate our scientific breakthrough into appropriate application in the field. PEPFAR has really realized it has a central role to play in being a strong platform off of which we can rapidly move to scaled studies that also allow us to move to scale in treatment therapies. Opening it up now to just general discussion around those issues.
Well, one consideration is, again, these developments are really, truly stunning. But the question becomes implementation. How are people actually going to get access? How are people going to pay for some of these treatments and preventive measures? How are we going to muster the political will in a very difficult climate? Well, actually, it's always difficult as far as I can tell, but it's especially difficult now to get these things done. I mean, that's really a lot is known. And even more has been, as has been repeatedly said, even more has been discovered in the past 18 months. But how do we actually implement all of these things? That, to me, is actually the biggest question.
There are really some very important policy issues that are emerging that I think everyone is aware of, particularly around the issue of the point that you made with your question to me, Eric, about pre-exposure prophylaxis. We have to be really careful how we begin to implement that. I think it's going to be different. There's not going to be a one-size-fits-all. It's going to be different from country to country, prevalence to prevalence, incidence to incidence, how many people are infected and are not receiving therapy. What is a good mathematical model, if any, of cost effectiveness if you prevent X number of infections in a country that has X number of infections? What is the cost effectiveness of really even trying to use therapy to prevent infection? I don't have the answer to that, and I think it's going to differ from country to country. But what I would be disappointed at is if we didn't really get the best minds, the best modelers to analyze that and make it an open area for discussion, because there's a lot. This is just a proof of concept. Now comes the real work. You know, I recall when the model was brought forth from the Greenwich model of treatment as prevention. It was kind of gave the wrong impression to the world. It was like treatment in a vacuum is going to have the AIDS epidemic go away, which had people sour to the concept of treatment as prevention, when I think that was a mistake, because there are certain aspects of treatment as prevention that absolutely will work. So we got to make sure that we take this incredible concept that's come forth and analyze it and put it in the right context.
Yeah, Chris.
Yeah, I mean, I agree with that. Of course, I think one thing that's going to be interesting about PrEP is it's going to challenge the system that we've set up. I mean, PrEP is going to require targeted intervention. It's not something everyone's going to want to use. It's not cost effective to try to get to everybody. It's just not going to be that kind of product. It's for targeted use. It's for folks who want to comply with the regimen who are at elevated risk. It's very exciting. I think it's important to point out this result was in gay men and other men who have sex with men, a population that has been neglected for many years around the world. Certainly I commend PEPFAR for increasing efforts around the MSM epidemic. But the fact that we have a new tool that can work in gay men is very exciting, both in this country and internationally. But again, it's really going to challenge all of us. How do we create health systems that can identify folks who feel safe coming forward to use this and help them use the regimen? And then also, of course, monitoring. You've got to be in a doctor's care to use this. You need to be monitored on an ongoing basis, HIV testing regularly, all those pieces. So I think it pushes the system, but in a perhaps very positive way.
Hi. I wanted to follow up on Dr. Fauci's comments about treatment as prevention and thinking about antiretroviral treatment as a way of reducing new infections. In San Francisco, over the past several years, we've initiated a series of comprehensive combination approaches to HIV prevention and care through the health department and our community-based organization colleagues and partners. And we've seen an increase in expansion in testing, identifying people at higher median CD4 counts. We've seen a decrease in the number of people who are unaware of their HIV serostatus from mid to higher 20s to 15 to 18%. And most importantly, we've seen a massive increase in the number of people, all people living with HIV in San Francisco, who are suppressed in terms of having an undetectable viral load, from over half to approximately 3/4 in 5 years, from 2004 to 2008. And that's only going to expand with the newly available antiretroviral regimens that we've had. And during this time, we've been able to follow community viral load as well as these other surveillance markers to show how well we're doing in terms of implementing these combination approaches. And it's also been able to highlight the places we could do better, including retention and engagement in care, and making sure that all San Franciscans and all Americans share, and people worldwide share in the benefits of antiretroviral therapy, not only for their own individual health, but it's one time when the benefits for the individual are aligned with benefits for the community in terms of helping people live longer and healthier lives, as well as reducing transmission.
Good point. Jen, did you want to say something?
Yeah, I'm just going to add three things, most of which have come out in different ways, that I think are essential to consider in implementing this intervention or any other intervention that is really bridging prevention and treatment in many ways. First is assessing current access, because current access, as in San Francisco, which is going to be much higher than in other places, current access to treatment for those who are infected has both an ethical relationship to introducing something for prevention, as well as a bearing on the modeling that Dr. Fauci was talking about. Second is combination, combination, combination. No matter what new intervention we have, combination interventions will always be needed. And the third is community engagement. Going back to the local again, getting communities involved to understand and provide their own input about what kinds of combinations actually work. If in reading the research that you do, looking at social determinants and factors that elevate people's HIV risk, clearly understanding those within communities is going to be critical to figuring out the right combinations.
Yes. I think that our ability to move these advances into benefiting the populations that we are attempting to serve has always been a critical challenge, both domestically and internationally. Our PEPFAR challenge has also been confounded by issues that really move from discrimination into really human rights issues, where the barriers that are being put in front of the population trying to access services increase because of comments from political leadership or legislatures or from the community. And the only thing that is going to move against this is really our understanding of the critical role community empowerment plays in modulating and pushing back around those belief systems and those points. PEPFAR is very focused on trying to understand how we can move that now in to the next wave of focus for us to nurture and empower communities. I'm curious if any of you could speak to some of the discrimination barriers to care, both domestically probably, that you have seen and are critical in your mind to diminish, to allow for these issues of access to be eliminated.
Well, certainly we see there are lots of areas in which we see discrimination that is a barrier to entry to care. For example, in thinking about some of the problems of rural areas, particularly the rural South, I mean, we see not only direct racial discrimination and class discrimination, but in addition, we see problems related to geography, just the incredible distance that people are from care. I have patients actually who travel easily 3 hours in one direction to get to me. Another problem that people in rural areas face, particularly the rural South, is a problem simply related to population density. You know, they have, under the current funding schemes, their funding eligibility schemes, they often receive less funding by virtue of the fact that the population density is lower. Another issue is the fact that some of these poor states where there's a large rural population, some of these southern states where there's a large rural population are extremely poor, have highly problematic Medicaid eligibility and Medicaid funding. And these are some very concrete things that affect people's ability to get medical care, ability to get HIV testing, ability to get care, ability to get access to drugs. I mean, people who, in fact, know they're HIV positive, for example, were eligible for antiretroviral drugs and who wanted them, in many cases during the past year because of the problems with ADAP, simply could not get drugs.
I think, the issue around women and girls being disproportionately impacted by some of these barriers to care domestically. The Southeast corridor, going from Texas to Florida, heavily dominated with rural issues around access. It's been that way for 30 years. And if you look at other disease processes in which you see huge disparities, you have the same issue. That same corridor comes up. I'm curious if there are models or examples of attempts to really minimize those barriers, either really domestically, I think we should focus, that you may be aware of that you think we should try to bring to scale. disseminate. Please.
I think one important intervention that's worked in other diseases started in Harlem with breast cancer and noting the disparities among breast cancer diagnosis and survival among African American women in New York City is the use of patient navigators and other types of interventions to support navigating through potentially hostile or discriminatory health systems and complicated health systems. I know helping my father navigate through Columbia's lovely healthcare system that's done great things and keeping him healthy is a challenge for me, and I was a doctor who trained at Columbia, and sometimes it's hard for me to figure out what I'm supposed to be doing and where I'm supposed to be taking him for his labs. So it's helpful to have, and the concept of navigators or promotoras or accompagnateurs have been used domestically in inner city urban settings to help address substance use, mental health, discrimination, and also internationally, with Partners in Health in Haiti, Rwanda, et cetera. So that's one intervention that's been successful both in breast cancer. It's being looked at for diabetes and other chronic diseases. And as HIV moves more into a chronic disease management model, we need to learn from other experiences and other diseases on how to help reduce disparities. And I think navigation is a great intervention for its potential for improving engagement in care.
I want to actually expand our discussion around discrimination and stigma to include the broader stigma that still exists. And I'm usually a glass half full person, but it's very disheartening that there's still so much stigma around HIV in this country. And that just has to be a continual battle that we all take on, and that does have a national implication as well as, again, local implications. And there's no magic answer to doing that. It just is again and again as I think it's changing with younger generations. One of the things I'm really excited that we announced today, earlier today, is a new partnership with the NBA and something with Walgreens, two very different kinds of private sector partners, but ones that you don't usually associate with HIV necessarily, both using the assets they have best. NBA has basketball players and lots of attention and very expensive seats or something, and Walgreens is the largest drugstore in the country that has a Walgreens in almost every community, are both using what they can do best to get out HIV information. I think by virtue of doing that and making it much more common to see information, to get HIV screening, it helps. It certainly can't help alone, but thinking about the stigma that still exists in this country, it's how do we straddle the really focused intervention for the patient, for the individual, as well as change the general culture in the country.
I think that the issues around discrimination permeate the PEPFAR family of issues as well. Our ability to engage them has been through the work of our implementing partners and the patients that use the services that we have put in place. We have had the emergency response. We were moving to more sustained responses now. The third wave, as we were alluding to, really is that empowerment of community, because it allows the safe spaces to be created so the pushback and unacceptability of the behavior is engaged and diminishes itself as a barrier. I'm curious if there are thoughts on specific types of strategies that you're aware of, the bringing in the public-private partnership strategy as another arm of resources that we can converge on some of these issues. PEPFAR has put a lot of effort into public-private partnerships to help support and deliver technical assistance to our partner countries' leadership in the ministries of health, in their ability to set up reference labs, surveillance capabilities. All of those types of technical skills are frequently found in private sector multinational organizations that actually are in and around all of the sites we're in. We've been very gratified at taking advantage of that, but I'd love to hear you kind of speak to the added utility that a PPP type approach may afford. Or Chris, too.
Yeah. Well, I mean, I think part of the equation has to be community-based organizations, people who are trusted in the community, who can reach folks that government employees and people in the general health sector can't. I think the move towards more country ownership and health system strengthening are absolutely positive places to be going. But as we go there, we've got to realize that MSM behavior is criminalized in almost 80 countries around the world. Many of them where PEPFAR is operating. So it's going to require the NGO sector to be playing a really critical role as we move forward. I think that's the fact that the AIDS movement has always been about thinking about most at-risk populations in addition to general efforts is one of the strengths here, and why is I hope that as we move towards the Global Health Initiative and broader delivery of broader health services, which I think is a wonderful thing, let's not lose the strengths of what this AIDS response has been and all the strengths that we've seen in PEPFAR over the years and under your leadership. I think that we know that AIDS has a tremendous impact beyond the number of people personally affected on family income, leading cause of death among women. It is the most robust platform on which to build broader health services. And let's be honest, in terms of politics, PEPFAR has bipartisan support at a time when budgets are really tough. So I strongly support where the Global Health Initiative is going. I think we need to be thinking about most at-risk populations in GHI as we move forward, and PEPFAR can be a big part of that picture. So I think the lessons of AIDS and the strength and the focus of PEPFAR needs to be absolutely critical going forward.
And just to add on the, I completely agree that the role of NGOs and community partners is not just, it's defining how the AIDS response happened everywhere, so it's critical. Just to add on the PPPs, public-private partnerships, I mean, it's an obvious thing, and you alluded to it already, but it's really understanding that different private sector partners have their own niche, their own specialty, and it's not asking them to do things that they don't do. It's asking them to do what they do, but potentially have it have broader application. And I think what we found is private sector partners, whether it's the NBA, Walgreens, CBS, Fox News, and actually we're a new partnership focusing on gay and bisexual men with Logo and Hear Media, that they want to do things. They really, really do. They just want to have it fit more with what their approach is. We're public health experts. They're not. They know how to reach people. Or how to, provide information in different ways. So it's a simple thing, but I think that's a really critical piece.
It is a really critical piece. When I think about just at the point when you came into the Kaiser Family Foundation, that epiphany seemed to be very much part of the shift that we saw in Kaiser Family, realizing the importance of engaging journalists and media, but also the private sector in a different way to look and tease out, define their responsibility to that larger burden. And I would just commend the Kaiser Family Foundation for having seen that many years before most of us, but also really very much want to find an entity in many of the countries that we're in PEPFAR that can play that same kind of catalyst role, the honest broker, the agent that will present the information so we can't ignore it and have to continue to look at it. We're very actively trying to figure out how we can kind of generically institutionalize and infuse that capability in many of the settings we're in. Any other thoughts that people were just dying to put out there that I didn't tweet? Chris?
I want to congratulate you on the treatment numbers that you announced today. I think that what PEPFAR continues to accomplish is something that we should all be really proud of. And I know that a lot of that is because of your leadership and leadership of your staff finding efficiencies in drug pricing and supply chain and other sorts of things. And I know that and that's what's allowed scale up to happen in the place of little funding growth. And in the future, efficiencies don't last forever. So I'm really hoping that as we move forward, we see this as a great investment for the United States, a great place to increase investment to accomplish our humanitarian goals, but also our diplomatic and security goals. It's paid off in the past, and I think it will in the future. So thank you for your leadership.
Well, thank you for saying that. It's very kind of you to say it. I think that we are acutely aware of the moment we're in historically as the congressional leadership has changed. and the importance of all the things that you point out now, really identifying programs that allow for a bipartisan dialogue and approach to move forward. We hope that PEPFAR can continue to play that role as we really try to address the large burden of unmet need that we are all looking at and all speaking to today. So thank you. Yeah. So I guess that we want to go a little further on and give another opportunity to cover some of the issues of I guess I would ask, are there lessons that you have identified from your work domestically that you feel are effective at eliminating barriers, especially for the African American population, for women in particular, girls, that you've kind of identified in your work that you would think, we know this, we should bring this to a scale in not only this city or this neighborhood, but really more broadly? I'm just curious if there are those types of issues that you've identified.
Well, I guess, again, what I would answer is something that's related to that, although it doesn't necessarily speak directly to it. There are two things. I think that we really do need to make much more effective use of the mass media for informing people and also for changing people's behavior. Not simply through, what people perceive as sort of tired public service announcements, but, really use the lessons of advertising to develop more, effective ways of changing behavior and changing norms. Another thing, again, and this is, so that's one thing I would say. Another thing that I would say is that, actually in looking at the lessons from Africa and how they apply to the United States, and thinking about the success of Uganda, actually, in decreasing HIV infection, I mean, one of the things that has been pretty universally agreed on is that a fundamental a fundamental component of their success was a tremendous political commitment and political will, where they really marshaled their efforts, for social media, social marketing of condoms, for mass media campaigns to decrease concurrent partnerships and other forms of multiple partnerships, where they really went all out and had actually incredible political commitment to do this. Well, certainly, I think we in this room would agree that there is a commitment on the part of the administration. What we need is somehow to get the rest of the nation on board. If we had the political will, I mean, there really is absolutely no telling what we would be able to do to get rid of AIDS in this country, and certainly in the world.
I've been impressed with, there's a role for government, there's a role for private sector, both in the PPP context, but also in the health profession context. What have you identified in the teasing out the responsibility from the community itself? And I mean specifically talking about African American community, Hispanic communities in the United States. It's a dialogue and a two-way street. What can the community be challenged with that they need to focus on and integrate into their behaviors?
So unquestionably, we talk about social factors that play a role in setting up people for getting HIV infection. But certainly, there's no question but that people have a responsibility for their own behavior. I mean, there's no question about that. I think that clearly one thing, and it's being done, is working with, for example, the black clergy. Mm-hmm. We have a project that does that. That works with the black clergy to specifically address safer sexual behaviors. And the point because their voice clearly needs to be heard. They're a respected force in the black community. And they have a considerable amount of power to help change people's behavior. But I think unquestionably, there is a clear responsibility for people to change their behavior, to make their behavior safer, to change norms in the community. And it's my impression that people don't disagree with that. In fact, we've actually been pretty successful in getting clergy on board to help with that effort. I don't know what other people have to say.
Well, I'd like to ask you, Adewara, if years ago when it was very clear that the trend was towards more and more relative percentage of African Americans getting infected, and now you know the new infections, it's 53% men who have sex with men, half of whom are African American. From your vantage point, with a lot of the experience that you have in your own position, what do you think we can do as a community to catalyze a bit more the African American leadership to come out? Because I remember right on 16th Street giving this fiery talk to African American clergy about what they really need to do to come out and really reinforce the need for people in the African American community to take the responsibility of avoiding getting infected. I felt a little bit awkward, a white guy in a suit going telling a bunch of African Americans who know a hell of a lot more about their community than I do. But I've been disappointed in seeing that I don't think they've stepped to the plate as much as they should. And if not, how do we get them to step to the plate a little bit better?
Yeah, that is a great question. And I mentioned that actually I do have this project that works with, and it's NIH funded, in fact, that works with.
That's why I asked you.
You help fund it. That works with clergy. I have to say that I think it is probably quite difficult as a person of different ethnicity to sort of. It can be seen as kind of an indictment of people. And one way that we did this is through, well, first of all, I'm obviously black, and also working with a co-investigator on this project who is also a black pastor. So sort of, explaining the whole context of problems, and not simply approaching them with, a single message of people need to use condoms, people need to use condoms. Part of the focus is actually getting them to understand that there are measures that they can recommend that are really consonant with their theology and consonant with public health, and that they need to do that. And they actually end up agreeing. Now, I have to say, this is not huge numbers of pastors, but there certainly are, this is the South, this is North Carolina. People did get on board. When they were approached by, a black physician and another black pastor, and when they got, sort of epidemiology background that's geared at, African Americans and HIV, they actually were very interested and did develop the sermons.
I think another important element of this is I would just like to reference research done by Greg Millett, who now works at the Office of National AIDS Policy. This was, I think, 3 years ago. He published a meta-analysis on black gay men in the United States. He looked at the evidence, and it suggests that black gay men aren't any riskier than any other type of gay man in the United States in terms of their risk behavior. But there are some things that are different about black gay men. They're less likely to know that they have HIV if they're living with HIV. If they're living with HIV, they're less likely to be in treatment, so less likely to have the viral load controlled. They're less likely to have an STI diagnosed and to be treated for an STI. So we're all human, and when a black gay man enters into that world, there may be a higher community viral load in the field in which he's playing. And so, I think it's also not about just saying, this isn't just, let's not stigmatize behavior of black gay men here. And a lot of what's going on here is people don't have the same access to treatment historically and presently. There's higher community viral load in this community, it appears. And so in addition to these social things that we've got to do, we've just got to do better at getting treatment and other health services to people to control community viral load so that if people occasionally slip, which it turns out people do sometimes, the risk is greatly brought down that they'll be exposed to virus. We can do this. It's Dr. Doss is looking at doing this kind of thing. It's happening in Massachusetts. It's happening in other places. There's a lot of hope here that this approach can be really important.
I would just add and underscore something that you brought out a few times, which is community empowerment. And I think if we approach this as not problematizing, but really about empowerment from a community perspective, actually the thinking behind the greater than AIDS concept, which came from something that President Obama himself said, but we can be greater than this. And that sense of empowerment versus an individual feeling stigmatized or problematized or in it alone actually is, I think, a motivating contribution. So.
Thank you.
Yes, we'd like to take an opportunity and give the audience a chance to ask some questions, Ambassador Gooseby, if that's okay.
Good. Let me
Question?
open it up to anyone who had a question. We could take a couple of questions. You know, I think I would ask, with the national strategy, was there a component that teased out the role for private sector PPP type strategies to move forward, or was that kind of left up more to how the individual 12 kind of sites might relate to it at the local level, or was there a larger planning thought to that? Do you know? Do either of you know?
You know, I mean, well, the strategy speaks to the critical role of the private sector. I don't know that, and I think actually private sector elements are part of the implementation plan we got in July. And it's also important to point out that ONAP has organized private sector. They had private sector folks and funders here for a meeting several months ago. They've organized a follow-on discussion about how the private sector can be engaged. So I think that's in development. I don't work at ONAP, but my sense is, you know, certainly they're engaging on those issues, and it's going to be central.
But I do think that is one challenge of the implementation. It's hard enough to implement across government, but to get the private sector and communities engaged is it can't be the federal government doing that itself, but there has to be a partnership.
We have a question here.
Thanks very much. I just would like to, first of all, also thank Ambassador Gooseby for your leadership on the MSM issues in developing countries. That has, you know, it's kind of incredible 30 years on that we are sort of discovering that there are gay men everywhere in the world. Some of us kind of intuited that, but, and, you know, that population or those populations are so markedly underserved and really are in some ways going to be, I think, an enormous challenge for the next phase of the response. I guess the question that I have is that this is one of those areas where you think about the lessons learned from PEPFAR, lessons we'd like to learn from PEPFAR for the US epidemic. In some ways, when you look at the rates in African American and other minority MSM in this country and what we're seeing in developing country MSM, you really wonder if there are not unlearned lessons all around with how we're going to, you know, respond to these challenges. I think the community empowerment, community capacity building piece is critical. But of course, what we're faced with in a lot of settings, the recent attacks in Kenya with the Prime Minister speaking out yet again against gay people, are governments that are hostile to community empowerment for this group. I guess I would ask you, wearing your ambassadorial hat, you know, what ways forward you see for this part of the response? I mean, we all know that this is an immensely tough challenge.
Well, thank you. I know you know as well as anybody how difficult it is to push this agenda. I do believe that it is acknowledging that our ability to partner with the NGO community frequently plays a critical role in putting program to ground and creating safe space so individuals can feel free to reveal themselves to their medical providers and not feel as if it's revealing themselves to community or to authority. It's a fine line to walk. We had to walk it domestically initially. We got reasonably good at it in the United States, but it is because of that community empowerment that it became truly safe space. I think the legislative complement to that is in our Disabilities Act, allowing individuals to have a legal foundation on which to prosecute discrimination. It should be acknowledged and looked at that way. I believe the WHO in a normative role has a role to play in defining that. The human rights issues around that need to be prominent in discussion and leadership. Secretary Clinton has been articulate in challenging ambassadors in the State Department to include this in their portfolio of dialogue with country leadership. She's enforcing that, and we have seen progress with it. It is clear to me, though, that we will not win that discussion with a U.S. government-imposed dialogue, but that we put and keep the pressure on to have the dialogue, and then we look for opportunities and ways to create conduits to support that empowerment kind of evolution that needs to occur with indigenous community-based organizations, to give them the knowledge and understanding of colleagues in other countries that have already walked this path, and to try to support, again, that complementary legislative legal framework in which it becomes the grid against which this really does move forward. It's a challenge that I think is in front of all of us with MSMs, with injection drug users, with sex workers, and in the lack of empowerment frequently seen in women in many of the countries, in almost all of the countries that we work in. They can be viewed in the same way, needing the same type of opportunity and structural support to create those safe spaces. I'd be curious if any thoughts on this. I know this group has been in and amongst these issues for many years, but if there were. Yeah. Any other questions? Yeah, Seth.
Like others, I want to commend you and everybody for the leadership that's been shown. Globally, it's not only concern here, because the U.S. is the largest funder, but globally we're beginning to see declines in interest in HIV. Recently, a prominent European country that has been a very strong supporter of HIV recently has downgraded that as an important priority. That's the Netherlands, a place you wouldn't have thought that to happen. There's a lot of movement to the right of governments. What are we doing, and how do we think about that as a factor that could have enormous influence on the global issue, particularly at a time when we've got all these fabulous new interventions that make it possible to talk about being able to finally really control this epidemic and be able to treat every person that has the disease because of the fact that we'll be able to control it. I worry enormously about that.
Well, I know Chris, did you want to react to that? Sorry.
I will. Yes,
go
but
right ahead.
okay. Well, I mean, I think that's really concerning, and you know, I think a few things. One is, I think the science is leading us to a place where we can change the curve of this epidemic, and I think we have to get better in talking with policymakers about the opportunity here. It's not growing programs for the sake of growing programs. It's investing where we've seen payoff in order to change the course of a terribly devastating epidemic in the United States and around the world. So, I mean, this is a good investment. And the new tools we're getting online, they've got to be used strategically. We have to be more strategic in the way we use them. But if we do that, we can really change the way this epidemic looks. And in the process, you know, again, the response to AIDS is the health system's builder. It has been that. It has been a way to get health services to people who didn't get them before. It's changed many people's relationship with the health system, knowing that treatment is available. It's changed what it means to be a healthcare worker in many countries. So, I mean, I think we need to talk to policymakers about how we've seen payoff from the investments here, the enormous opportunity to slow down this epidemic and build health systems while we do it.
You know, Seth, you bring up a really good point that's really very troublesome, and particularly the issue with the Netherlands, which is not a country any more or less involved themselves, but had the foresight for years to make investments and now have decided, because of the economic situation, to pull back. I'm not so sure there's anything we can do about that given the economic times. So what I think about is maybe the possibility of getting the countries with extraordinary involvement, namely the countries in which there is a major problem in their own country, to realize as we get better tools that we were talking about this afternoon, that, it's almost like a drug company where drug companies tell us, you do the research, you give us a concept. Once we get a concept that we could see the light at the end of the tunnel, we'll invest all the money you need to go after it. Maybe we could use a little bit of a modification of that argument for some of the countries that have the real big problems, that if we now have the tools, that every year we get more and more tools, that then they will see that it would be for their benefit to make a major investment of their own national domestic product to put money in to make that happen. I think we're going to see that with the vaccines. I think we're going to see that with microbicides. I mean, we're seeing it with circumcision.
Right.
So I think that as we get more and more proven tools, we can get the companies, I mean, not the companies, but the countries that are most heavily involved to actually step to the plate.
Thank you. Right. Ambassador Goosby, thank you very much, and thank everybody on the panel. We're going to turn it back over to Jeff.
Great. Thank you, everybody. I thought that was a really rich discussion, and I'm glad we had the opportunity for it. Now it's my pleasure to introduce the Secretary of the Department of Health and Human Services, Kathleen Sebelius. Madam Secretary.
Well, good afternoon, everybody, and thank you, Jeff, for your work and leadership in this area, and I'm really happy to be with all of you today. I want to thank Melody Barnes and certainly our great leader at HHS, Dr. Tony Fauci, Ambassador Goosby. It's nice to always join you and other panelists who have been here today. I know that this is a gathering of advocates and care providers, stakeholders, policymakers, and others looking at where we've been and where we need to go in the fight against HIV, AIDS. And we're talking about efforts not only here in the U.S., but around the globe. And I think there's some very good news to share and also a lot more work to do. I know today is World AIDS Day, and it really represents a special moment, a moment to remember those who have lost their lives, honor those who are in the fight, and also rededicate ourselves to an effort moving forward. But at HHS, every day is World AIDS Day. We have a lot of talented folks who spend each and every day focused on these issues and these initiatives and our effort to move it forward. We have a lot of gains to celebrate, and I think it's a time to look ahead with hope, but also rededicate to the purpose of our collaborative efforts. Now, since we were together a year ago at World AIDS Day, there are a number of significant milestones, important advancements in scientific research, a historic increase in testing across the U.S., and certainly the passage of the landmark health reform legislation, which will provide a base of coverage under millions of Americans who never had that opportunity before. So a lot has happened over the last year, but we certainly need to keep that momentum going. We need to keep the scientific endeavors moving forward. We need to redouble our efforts on prevention and make sure the care and treatment is provided to individuals living with HIV/AIDS. So we've come some important distance, but we have a long way to go. In the last year, with the President's leadership and the dedicated work of lots of scientists, policymakers, people living with HIV/AIDS, again, there are some steps forward. Lifting the entry ban on HIV-positive travelers was an important step forward, and one long overdue in this country. Now families can be together, and we can once again welcome people to the United States who should have been able to travel here years ago. The President signed a law ending the longstanding ban on most federal funding for needle exchange programs, giving us more opportunities to stop the spread of HIV injecting drug users. Again, an important initiative forward. We reallocated an additional $25 million this year to extend care to people on state waiting lists. Now, I know that there's still a lot of frustration that that additional resource still didn't keep up with the drop, the precipitous drop in state and local budgets, but we're continuing to work with states on how to make sure those allocations reach the most affected populations. And in the last year, we're beginning to use new media to build a cutting-edge response to the epidemic, targeting HIV prevention, testing, and treatment messages to the people who need them the most. It's the first time in a long time that we've really focused on a domestic AIDS strategy and reaching out through channels like AIDS.gov to meet people where they are, to educate Americans about HIV, and to reduce the stigma and discrimination. Now, our scientists, as you probably heard, have had a good year as well. In July, the U.S. government scientists and policymakers joined colleagues from around the world in Vienna for the International AIDS Conference, and they heard exciting news about the successful trials of microbiocides that will one day protect vulnerable individuals, particularly women, from HIV infection. And in the same month, HIV-led scientists have found antibodies that prevent most HIV strains from infecting human cells. A growing optimism is there that we're getting closer to find a way to stop HIV before it gains a foothold in the human body. And a little over a week ago, NIH announced the results of a large international study which found that HIV-negative men who have sex with men and transgender women who have sex with men who took a daily HIV treatment drug were significantly less likely to become infected with HIV than were the test group who took the placebo. Now, the implications for this research for preventing HIV transmission in an at-risk population are really exciting. And the one common thread that runs through all of the accomplishments is the power of investment and collaboration. It is evident in the new health care bill we passed in March, the Affordable Care Act, which provides better and more comprehensive care to people living with HIV/AIDS, and is perhaps the most significant piece of HIV/AIDS legislation since the Ryan White legislation was passed. And that's why when we began working to develop the national strategy, we started reaching out to doctors and people living with HIV/AIDS around the country, researchers, health workers, activists, community leaders, and academicians. Over and over again, we've seen that we make our greatest strides when we work together, guided by the most up-to-date science, sharing an understanding of the challenges we face, and building on a platform to take them on. But there's a difference between knowing where you need to go and actually getting there. So implementation makes all the difference, and we know we have to get it right. HHS has a lead role in implementing the new strategy, and we're working closely with our colleagues at the Departments of Housing and Urban Development, and I saw the Secretary walking down the driveway as I was coming up, so I know I had a chance to speak with you. The Secretaries of Labor, Justice, Veterans Affairs, and the Social Security Administration are all part of this collaborative strategy. Next week, all the departments and agencies will submit operational plans to the President, detailing how we intend to implement the strategy in 2011 and 2012. We've already committed $30 million from the Affordable Care Act's new Prevention and Public Health Fund to support new and existing HIV prevention efforts, and will continue working under the new law to provide better and more comprehensive care to people who are living with HIV/AIDS by expanding Medicaid and creating new health care marketplaces in 2014, where affordable coverage will finally be available to all, and plans, finally, in this country, will be forbidden from denying people coverage based on a pre-existing medical condition. In addition, benefits under the AIDS Drug Assistance Program will be considered as contributions toward Medicare Part D's out-of-pocket spending limit, a huge relief for low-income seniors living with HIV/AIDS. But having insurance doesn't necessarily mean that you're going to get a doctor. So the new law also makes a huge new investment in our healthcare workforce, with a specific focus on getting more doctors and nurses in underserved communities, and that remapping is being done right now, so we have the most up-to-date snapshot of underserved communities, and making sure they have the cultural competency to communicate and deal effectively with all types of patients. We're doing this with the support and guidance of healthcare providers, community organizations, patients, and advocates who bring their experience and perspective that's absolutely essential to inform our work and for that work to take root and thrive. You can see the coordination across our department and with local partners in our HHS 12-City project, an innovative effort to support comprehensive planning and cross-agency response in the 12 communities that are hardest hit by HIV and AIDS. At the program's core is the idea highlighted in the new national strategy that by concentrating resources where the epidemic is the most severe, we can make the most significant impact. Together with local grantees representing 44% of the HIV epidemic in the country, we'll be able to support coordinated planning, mapping federal resources in every jurisdiction, and addressing how our HIV resources and services can best be distributed. Now, that's a really exciting opportunity to take the best science, medicine, and behavioral information that we have and use it to make a real difference for people living with or at risk of HIV and AIDS. So the lessons we learned from the 12 cities will be disseminated across the U.S. to keep improving and refining our response to HIV and AIDS. It's just one of the many innovative steps we're taking today that we think will really pay great dividends in the long run. Now, it's been 23 years since the first World AIDS Day, and this year we do have a number of reasons to be optimistic. But none of this will be possible without those of you in the room today, and countless people around this country and across the globe who have made this fight their daily cause. When he introduced the strategy, President Obama said that the success will require everyone's commitment and everyone's participation. And together, we finally have a roadmap, and now we look forward to going forward together. Thank you all very much.
Well, this concludes today's event. Thank you very much for coming. You know, as we wrap up, clearly we have significant challenges ahead of us, but we're also making significant progress. And I think, you know, in Dr. Fauci's words, it's a bittersweet day. But I do want to leave you with the idea that, you know, we have a firm and consistent leader in President Obama, and him working along with Secretary Sebelius, Melody Barnes, Secretary Clinton, Ambassador Goosby, Dr. Fauci, and so many people across the federal government. I think you see that you have a strong partners who are working every day to end the HIV pandemic. And so we just want to say thank you to all of you for your ongoing partnership with us. Thank you very much.